and welcome to today's webinar. My name is Shafia, and I will be talking to you over the next 45 minutes with regards to how you can introduce IV sedation in your everyday general practice. So just a little bit about myself, because I am a new speaker to the female dentist. I graduated from the University of Manchester in 2014. I'm a dentist with a specialist interest in oral surgery, and I've been doing oral surgery and sedation for about the past 8 years. I work day to day in a tier 2 oral surgery practice. So that includes taking out impacted wisdom teeth, removing broken roots, and just treating very anxious patients under sedation. I also do place some dental implants. I don't just take teeth out, I do actually replace them sometimes. I am an accredited sedation trainer, so that means I can train dental nurses and dentists to become independent sedation practitioners. I have currently just completed a postgraduate certificate in teaching and learning, and that's why I volunteered to do this presentation, just so I can teach other dentists and dental professionals what I've learned over the years when it comes to oral surgery and also with sedation. So this is just an example of something that I get referred. This is my bread and butter, that impacted wisdom tooth at the bottom. So it's a good idea just to go over the learning objectives for today's webinar. So we will explain the pharmacology of single drug IV sedation and how patient factors can affect this. Understand which patients are suitable for IV sedation in general practice. Recognise what constitutes an adequate referral for IV sedation. This is quite important, especially if you are referring patients on the NHS pathway. NHS Tier 2 oral surgery is very overwhelmed at the moment, with some patients waiting up to 4 months to be seen. So it is a good idea for practitioners to understand which patients are not really suitable to save them that wait. We need to gain an understanding in how patients are triaged once they've been referred to someone like myself, and recognise how the use of a mobile sedationist can improve a patient's treatment journey in your practice. So we just need to do a little bit of revision. So what is conscious sedation? So conscious sedation is defined as a depressed level of consciousness during which a patient retains control over their protective reflexes and can respond to commands. It's very important for the patient to understand that they will not be asleep. If there's one take-home message from this webinar, it will be, please do not tell your patients that they are going to be asleep. It's very important for them to understand this because their expectations
Hi, it's me, Cesar. We can't see your slides moving.
Oh. Can you see it now?
No. Could you please pull them again?
What am I up to? What can you see?
I can see your cover slide.
Oh, okay.
Try to probably close and open the file again.
Okay, let me stop sharing and then I'll do it again.
Sorry.
It's okay. It's okay. I don't know why. Okay, I'll just see if I can do it now. Okay. Can you see it now?
Yes, all good, I think. Can you keep... Yes, all good.
Oh, okay, thank you. Thanks for telling me. I would have just gone through this whole thing without you guys seeing anything. Okay, so we're on learning objectives. So these are just the learning objectives that I've spoken to you about. And we're just on conscious sedation. So you can all see this. Yes? I can keep going?
Yes, all good.
Amazing. Thank you so much. Okay. So conscious sedation, like I said, it's really important not to tell the patient that they will be asleep. As soon as you do say that, that's all they remember. They won't remember anything else about bringing a chaperone, having someone to stay with them for 24 hours, because to them, they're just going to be asleep. So they don't really need to listen to anything else. So it's really important for them to remember that they will be awake, they will be able to respond to commands, they will still be aware of the treatment, although the treatment will kind of feel distant, it will feel a little bit hazy. but they will still feel pushing and pressure. They will be aware of sounds, but they will probably forget this if you ask them 24 hours later. So just be aware of that. So let's talk about the drugs that we use. So midazolam is the main drug of use in NHS and private dentistry. I would say about 99% of cases are treated with midazolam. We do have some new drugs coming onto the dental scene called remimazolam, which is mostly used in private practice. But if you refer a patient on the NHS pathway, and to be honest, if you get a sedationist within your surgery, they will most likely be using midazolam. So midazolam is a benzodiazepine, and we'll just speak a little bit about benzodiazepines in the next slide. So to understand what benzodiazepines do, there's just a little flow chart here. So this will probably take you back to second year pharmacology, but essentially what a benzodiazepine does is it works on something called GABA. So GABA is the chief inhibitory neurotransmitter in the central nervous system. So think of your nervous system as a car on a track. GABA acts to put the brakes on that car in order to slow everything down and slow all the excitement down. What benzodiazepines also do is they enhance the neurotransmitter GABA at the GABA A receptors in the central nervous system. They boost the receptors. They boost the receptors in the neuron, which act on the body's own production of GABA. And this allows negative chloride ions to flow through more freely through the neuron, making it less receptive to other neurotransmitters. So the other neurotransmitters that we're talking about are adrenaline, noradrenaline, and dopamine. All these neurotransmitters will actually excite the nervous system. So obviously that's not what we want. We want a depression in the nervous system. And the result of this is a sedative effect, a hypnotic effect, anxiolytic, anticonvulsant, and muscle relaxant properties. And obviously that's exactly what we would like the patient to be. We'd like them to be nice and relaxed, sedated, and to get rid of that anxiety that's causing a real issue for them in the dental chair. The next slide just shows what I've just spoke about, but in a diagram form. So as you can see, the pink little semicircles at the top are the benzodiazepine. So they act onto the GABA receptors, and it just opens up that channel wider, so more chloride ions can flow through from out of the cell to within the cells. And this increasing chloride ions essentially just depresses everything down and makes sure that you get that sedative effect that you're after. So we need to understand that every patient is different, and the patient's, the way that they receive the sedation is going to be different. So even the same patient who's having sedation for the second, third, fourth time, their sedation is not guaranteed to be the same every single time. And that's because there's lots of factors that affect the patient, which can differ from day to day. So there's a few that I've listed here, and we'll go through each one in turn. So if a patient is taking benzodiazepines as part of their medical regimen, so some patients are actually prescribed these drugs as part of their normal everyday life. Studies have shown that these patients do have a higher tolerance to benzodiazepines as the body is so used to clearing them out. So they probably will need more sedation. And then you're probably looking at recovery times. So they might not be suitable for being treated in primary care. If the patient is pregnant, so benzodiazepines have been found that they may affect the fetus and also harm any pregnant mothers. So with pregnancy, we just usually kind of say, oh, wait for the baby to be born and for everyone to be better, and then you can just come back and have your treatment then. If a patient has marked liver failure, so benzodiazepines are actually first metabolized in the liver by liver-specific enzymes, and then they flow through to the kidneys to be completely metabolized. So if we have patients whose liver isn't functioning correctly, it might mean that they're sedated for a lot longer because we're unable to clear that drug out. So we just need to be aware of that. The next two, we'll take them both together. So patients who are taking opioids and patients who drink excessive amounts of alcohol. So what the benzodiazepine actually does, it actually increases the effect of these drugs. So it actually increases the effects of the opioids and increases the effects of the alcohol as well. And just anecdotally, I have found that it's quite difficult to sedate patients who have excessive alcohol amounts, drink excessive alcohol amounts. I don't know if there's science behind this, but I found that they just don't sedate very easily. And when they do sedate, they recover very quickly. It may be just because their body is so used to clearing out so many toxins that it just clears out the midazolam too quickly and it doesn't stick around to open up those ion channels that we spoke about in the previous slide. If the patient's BMI is over 35, so there's two kind of problems with this. The first could be just airway management. Sometimes it can be quite difficult in obese or morbidly obese patients. And also, midazolam can be stored in within the fat cells. So if there's obese or morbidly obese patients, they might get sedated later on. So they have a delayed response to the sedation. So in the chair, they might not get sedated quickly. However, when they go home, they'll feel very, very sedated and it will hit them a little bit later on, which can be quite dangerous. If a patient has mobility challenges, so if a patient is using a wheelchair, a frame, or on crutches, it would be quite difficult for them to be sedated just because it would be difficult for them to get in and out of the chair, for them to go home safely. And it's really important that they have an able-bodied escort, someone that's able to support the patient if they do, need a little bit of extra support. And I think probably the hardest one to actually deal with is patient expectations, especially, like I said, if patients have had sedation in the past. No matter what you tell them, they're always going to, compare it to the previous episode of sedation, which is fair because they've got nothing else to compare it to. However, they actually are not remembering it correctly. They might think that they were asleep. They might feel that they didn't remember anything, and here they can remember everything. But it's just that because time has passed, that's probably why they've forgotten. So patient expectations can be quite tough. So it's just like telling them, it's not the same every single time. So now we need to look at the cohort of patients that are actually suitable for practice. So we have some assessment scores that we need to go through in order to make sure that we are treating these patients safely. We're keeping the patients safe and we're actually, just being safe ourselves. So some of the scoring that we use is one called the ASA score, one's an airway assessment score, and making sure the patient has adequate venous access. So these three things are usually done on the pre-assessment, and this is something we'll speak about in further slides. So the ASA score, or the American Society of Anesthesiologists scoring system, is essentially a grid, like you can see in front of you. It goes from ASA 1 all the way down to ASA 6. Essentially, it grades patients into these categories before they have surgery. So for sedation in primary care, we are most likely looking for ASA 1 and ASA 2 patients. The majority of patients, the majority of the population is probably an ASA 2. Someone who has diabetes, but it's well controlled, high cholesterol, but that's well controlled with medication. So they do have an ongoing systemic disease, but they're able to control it and it doesn't really affect their life. So that's probably the patients we're looking to sedate. An ASA 3 patient is someone, for example, who has uncontrolled diabetes or the diabetes is not controlled too well. And those patients, it kind of depends on your sedationist, it depends on their experience, and it depends on other factors. So that just depends on the operator. ASA 4, 5, and 6 patients, you wouldn't see them in primary care. They're going to be more in a hospital setting, so you don't really need to worry about those. Airway assessment scores. There are a few ways to assess airway, but this one's probably the most straightforward for people who are not actually medically trained. So we're looking at treating class 1 and class 2 patients. And this is just because we can see the whole of the back of the throat, the whole of the soft palate in class 1, and we can see up to the uvula in class 2. So when it comes to assessing patients, I think the thing that you need to really keep in mind is if everything goes wrong and this patient starts desaturating, their blood pressure goes down, their pulse is racing, are you able to maintain that patient's airway independently in your dental chair? And if the answer to that is no, you can't really do that, then you shouldn't really be seeing like those patients, so a class 3 or a class 4 patient. So just err on the side of caution if you are going to be sedating or if you've got a patient who wants sedation, because we just need to make sure everyone's safe and everyone's healthy, and it's just less stressful for you as a clinician too. So venous access, so I've lost count of how many patients I've actually sedated over the years, but this is the one thing that will still keep me up at night time is venous access. It's so different from patient to patient to patient, and that can really be your downfall if they have really, really bad veins. So we're looking to cannulate them in either their antecubical fossa, which is this little bend that you have in your arm at your elbow, and we're looking for the cephalic, the basilic, and the medial cubical veins. So as you can see in this picture, they're nice and prominent. And we want veins to be bouncy. Essentially, that's where we're going to put the cannulas. So that's what we're looking for. These veins, these same veins then travel down into the hand. So you can see in this diagram, you've got the cephalic and the basilic veins coming down. So again, you're looking for the broader veins in the hand. You wouldn't go too much towards the fingers because these veins are very, very fine. And also it's very painful to cannulate on bone where you don't have a lot of cushioning. So that's why we try to keep it within the ACF or in the dorsum. So these are some of the reasons that patients get referred for sedation to someone like myself in primary care. So these are four reasons. There's probably one other reason that we can go through. It's not strictly why people get sedation, but I have seen it in the past. So these are the four that I could think of. So anxiety is definitely the main one that I see, especially now with how patients are always online looking at YouTube, TikTok videos of people being sedated or of dental procedures in general. It does heighten patients' anxiety because they just see the worst of everything is online. Also, it could just be a past experience if they've had a bad experience in the past or their family member has, or just anecdotally, they've got stories. Everyone said that, oh, having that wisdom tooth is so painful, and I'm finding it really difficult to come to terms with, so I just want something to help me. Procedure specific. So this is mostly for patients who have very little dental experience. Maybe it's a young, fit and well patient who has excellent oral hygiene, but unfortunately they've got bilateral, horizontally impacted wisdom teeth that keep getting infected. We've all seen patients like this, and they will need surgical extraction. From an operator point of view and from the patient's point of view, sedating them is probably an easier option, because they've never had anything more than a simple scale and polish. And you're basically going to cut a three-sided or an envelope flap. You're going to pull that back. You're going to do buccal guttering in the bone. And then you are going to either section or decoronate that tooth and obviously remove the roots and then suture. So actually, even for someone that's had a lot of dentistry, it's quite a lot of work to do in one session. So those patients might need sedation just to help them. I would also say that orthodontic extractions that haven't gone quite right. Again, I was a GDP for a long time before I switched just for oral surgery, and orthodontic extraction still strikes a bit of fear in me because it's just spindly little apex on the 4s and the 5s that, you just think, oh, am I going to be able to get that out? You have a go and you fracture the apex, fine. And then that patient, who sometimes is quite young, gets sent on to someone like myself, and they're already a little bit nervous. Their treatment's been delayed because obviously they can't have their braces done until the roots have been removed. And then again, you're going to be pulling the lip out, a three-sided flap, lots and lots of bone removal in order to get this apex out, and then suturing. And again, it can be quite uncomfortable and quite unsettling for patients because it's so anterior and so towards their eyes, so they can actually just see everything going on in front of them. So, those patients do request sedation, and sometimes I actually tell them you're probably better being sedated, just because it can be quite alarming for them. Patients that have a marked gag reflex, or that's something that we are seeing a lot more of. And what the sedation can do, it can just relax those muscles, relax that reflex. And also if patients have very limited mouth opening, so if their mouth opening is really limited and you're trying to do an extraction or a filling on a upper 7, for example, there's just no way you're going to get those instruments in. But they obviously need the treatment, so sedation is good for those patients. I recently saw a patient for another dentist. I came in and I was doing traveling sedation for them, and before they were sedated, they couldn't tolerate any intraoral x-rays. They were unable to have a BPE on the posterior segments. and they couldn't even have their tooth dressed. And once we had sedated them, they were able to have a composite filling done on a lower right 7 under rubber dam. It's amazing what sedation can actually enable you to do. And that patient was able to be seen in primary care with their own dentist, just because they were able to be sedated. And we need to remember that sometimes patients request sedation. So if they've had sedation in the past and they want sedation again, even if you don't think the procedure is too complicated or you don't feel like it's the first line for those patients, if they are eligible for sedation, then you should really be offering it to them. I'm not saying offer it to everyone just for simple scales and polishes, but some patients really cannot tolerate the feeling of the handpieces, the water in their mouth, the suction in their mouth. So sometimes patient request is something that you need to take into consideration. The final one that I want to speak about, which is not really technically strictly why we get referrals, but we do get a lot of referrals for failed anesthesia. So actually, to be fair, the sedation doesn't give you more anesthesia. It doesn't make the tooth more numb, or it doesn't deaden the nerve more. But what it probably does, it just that anxiety is gone from the patient, so they're more willing to accept another ID block, under the buccal infiltration, just so you can get all the local anesthetic in there in order to do the treatment. So again, it's just your halfway house reminder of please don't tell your patients that they will be asleep. You might be laughing at me at the moment, but honestly, I was sedating a patient for some implants, and the dentist told the patient in front of me that, oh, don't worry, you'll be asleep. And I was just like, no, please don't say that. It's really important that the patients understand that they're going to be in control. A lot of patients don't want to be asleep, and they find it really, overwhelming that they're not going to have any control of what's going on within their mouth. So for you just to understand that they are not going to be asleep, they are going to be able to respond to you, and they're going to wake up and walk out of that dental chair, just so that they understand what's going on. It can also mean that if you're telling a patient that they're going to be asleep, and someone like myself who's coming into the practice saying you won't be, the patient might not understand that why two dental professionals being conflicting over their treatment plan, and then you might lose trust towards me as a specialist or towards you as a dentist. So that's obviously, we don't want a breakdown in the patient relationship. So just be singing from the same hymn sheet. So once you've clicked that referral form, send referral on NHS referrals or your private referral pathway, how are these patients actually even triaged? So we do something called a preoperative assessment, or a pre-op. So this is just an appointment before they actually are sedated. It can be done in person, and more since COVID, it's been done remotely. So you can have pre-op checks on the phone, or you can have them over something like Zoom, like we're doing today, just so the patient isn't having to come out all the time to the surgery, and you as a mobile sedationist or a sedationist doesn't have to go in just for one patient. So the things that we're asking the patient are things like checking their blood pressure, their heart rate, and their oxygen saturation. So obviously, if this is in-house, it's really easy and straightforward to do. But the biggest question I had when I first started doing mobile sedation is, how do we check blood pressure, heart rate, oxygen saturation if we are not seeing the patient until the day? And the answer I got was, essentially, it's up to you what you want to check. So you kind of ask the patient to go along to the GP or to the pharmacy. They have blood pressure checks there. It's quite straightforward. Majority of them are free. So if you can tell the patient beforehand, before you're doing the pre-assessment, would you be able to get me a blood pressure check? It's probably more accurate, to be honest, because when the patient's in the chair, they're obviously very nervous of the dentist, and their blood pressure is absolutely through the roof, but that's not a real reflection of their resting blood pressure. So asking them to go to, the pharmacy, the health centre, and just having a quick blood pressure check might actually give you a more accurate result. BMI, so height and weight. Venous access, so we'd ask patients, we'd have a look, we'd make sure that they're wearing a t-shirt or loose clothing so we can get good access to their veins. Chaperone availability and childcare arrangements. So with sedation, they will need someone to be with them whilst they're having the treatment done. They'll need to wait in the waiting room all the way through their procedure. So if this patient is having a full mouth implant reconstruction case and it's going to take the best part of 4 or 5 hours, that patient's escort will need to be in that waiting room for the whole time, for 4 to 5 hours. So you do need to warn them. You can't just wander off and go to the coffee shop down the road. You know, you can't just go and have a little sleep in your car. You do need to be on the premises just in case anything it does happen to the person that's getting sedated. So they need to obviously have cancelled all their plans, you know, not need to go and pick the kids up from school or anything like that. They need to just be free for that sedated patient. And that goes into the childcare arrangements. So we do have lots of patients that have young children, and what we would suggest is that there's someone else looking after the children whilst the main chaperone is just looking after the sedated patient. It just means that the sedated patient has got the full attention of their chaperone, and obviously the children are being looked after adequately too, because it can be quite difficult to make sure that everyone's being looked after effectively, especially if the patient gets a little bit of a heighten in their sedation later on. You know, it comes in waves, so it might come a little bit higher later on, and they might need a little bit extra help there. But if they've got little children running around, that can be quite difficult to do. And just something like as simple as transportation. So I have had patients refusing treatment because they couldn't afford a taxi to the clinic. They're not allowed to take public transport, so they need to come home in a car or a taxi. So they had no one that they knew that could drive, and they couldn't really afford a taxi till next month. So we had to delay treatment for those patients. So just understanding that sometimes social factors really will, weave into that patient's treatment plan, and being understanding of that, and understanding that, okay, like, we can delay treatment just so you've got everything in check, and you've got all your chaperones ready, and you've got everything sorted. So I'm just going to move on to specifically why using a mobile dental sedationist is something that lots more practices are using now, and how that can help your patients. So essentially what happens is a sedationist will come to your practice and sedate the patients in-house. This means that your patient journey will be a lot smoother, and the patients will be seen in a familiar setting. Nervous patients build up a nice, trusting relationship with their own dentist. And if they are then asked to go to the referral dental practice down the road, they might find that very intimidating. They don't want to see anyone else. They've built up a really good relationship with yourself, especially if you've been in that practice for 5-10 years. You've got a really good relationship with them, and you don't really want them to have to go anywhere else. So that's when someone like myself will come into your practice and be able to sedate those patients for you. Because you're able to see those patients, you are then able to carry out more advanced treatments on a wider patient base. Some patients are fine with simple fillings, but when it comes to maybe endodontic rubber dam and root canal, they might find that really overwhelming, and maybe just not be able to tolerate that without something a bit extra. And again, if you don't offer sedation in your practice, you will then be referring that out to another practice, essentially disrupting that patient's journey, and also meaning that you're not doing more advanced treatment, so you're not able to do those tricky endos, or those full mouth rehabs that maybe you'd want to introduce into practice. It also is an additional revenue stream. Of course, if patients are staying within your practice, then obviously the fees for the treatment is within your practice. And in a world where prices are going up and revenue is going down, especially actually now in private practice. So private practice is becoming quite saturated. There's lots of practices that are offering private treatment, including cosmetic treatment, implants, and composite bonding, but actually there's not many payer practices that can offer sedation in-house. So again, it's just something to make you stand out and hopefully get you more patients. So the biggest thing I'm probably asked when I approach a practice about doing dental sedation for them is, how can we be CQC compliant? And the CQC have got a great website here, and they have Mythbusters, and Mythbuster 10 is specifically to do with safe and effective conscious sedation. So you can have a read of this. It's really straightforward, but I have summarized the main points in the next few slides for you as well. So that's just the CQC website. Go to the Mythbusters, and like I said, Mythbuster 10 is for sedation. This document is kind of the document that all sedationists should be familiar with. So it's the standard for conscious sedation in the provision of dental care. So this is the version 1.1, so it's been revised once. And this is a joint project from all the Royal Colleges, that's including the dental Royal Colleges, plus medical Royal Colleges and those of anaesthetists. And it essentially gives you a few points that you need to make sure that you're delivering in order to make your sedation safe for yourself as a practitioner and for your patients. And I've just summarised those in the next slide here. You can have a read of this. It's not too long of a document. It also goes over inhalation sedation for children. So if you are thinking of something like that, then do have a read of this document. Okay, so these are the main points that I pulled from the CQC and from the sedation guidelines. So what the sedationist needs to have is adequate training in conscious sedation. So that means that the sedationist must have undertaken an accredited course and then have to have 20 cases supervised by an accredited trainer. So that means they do a theory course, usually 1 day or 2 day. That can be in person and that can be online. And there's lots of courses available now close to where you are. And once they've done all the theory, they need to find someone like myself who's an accredited trainer, and they would need to undertake sedation cases with that trainer and satisfy someone like me that they are safe and they are able to do this by themselves. So sometimes they probably do need a few more than 20 cases, especially people who haven't done any type of DCT posts, because it's just the cannulating. That's probably the new skill that they need to learn. The more you do it, the easier it gets. So if you've had someone who's done 2 years in DCT and all they've been doing is cannulating people day and night, you find that those practitioners are really easy to pass. Whereas you have practitioners that have only done general dentistry, they take a little bit more time. Record keeping for controlled drugs. So midazolam is a controlled drug and it does need to be recorded effectively, and it does need to be stored properly. And we will go through this as we go through the presentation. So ILS training. So this is probably the second biggest thing I get asked is, okay, Shafia, we're happy for you to come and do sedation for our patients. However, we don't have anyone else that's ILS trained. So what do we do? So this just basically all boils down to who is doing what within the surgery. So if you have a patient that is being sedated by myself, but I'm not doing any of the treatment, so there's another dentist or a dental therapist that's actually doing the treatment, and they have a dental nurse with them, and both of those people are BLS trained, then it's adequate for me to be the only ILS trained person within that scenario. That's because I'm not busy with the treatment. I'm not within, looking for the apex of that root canal. I'm having a step back, and I can make sure that that patient is adequately oxygenated, adequately looked after, and adequately sedated. If you were to call me in and say, oh, Shafia, we've got a surgical extraction of an upper 7 that we need you to do, plus the patient needs sedation. So I've become then the sedation operator and not just the sedationist. And in that case, you would need another individual to be ILS trained. So that's like a sedation trained nurse or an ILS trained nurse. Obviously, the gold standard and the most ideal situation is everyone is ILS trained, but I'm just making you aware that it shouldn't be a barrier of giving your patient sedation. If you've just done BLS training with your whole team and you're not due for another year, you don't really have to delay having a sedationist within your practice. You can just get on with that if you keep to these rules. A clinical logbook. So it's advised for sedationists like myself to log down their cases and just to kind of grade the sedation, grade the treatment, and see how that's gone. Within the clinical logbook, I just want to have a little more of a chat about, well, do I really need a mobile sedationist? So obviously, anyone who's a dentist can be trained to become an independent sedationist. So you might be thinking, okay, Shafia, that's great. You know what I'm going to do? I'm just going to do the sedation myself. I don't really need you to come down. I'm just going to do it myself. So you go on, do your training with your accredited course. You do your 20 cases, and then you're like, right, I don't need anyone else. I can do this myself. But if you're only seeing 1 or 2 patients every 6 months, you're not really able to keep your skills up to date. You're not really able to understand what is a successful sedation. And it's a bit like if I'm a dentist and I'm only doing 2 fillings in 6 months, I'm not going to be as slick as someone who's doing fillings every single day. And that's what you need to understand. It's not the fact that you're outsourcing, you're just getting the best person in for the job. And you as a dentist are the best person to treat that patient because of all the factors that I've spoken about, the relationship, the setting, the trust that you've built up. So instead of, compromising all that to become a sedationist, it's a lot easier just to get someone else in to do the sedation for you. CPD relevant to conscious sedation. So it's advised that over a 5-year period, you need to do 12 hours of CPD. So this can be anything. It can be webinars like this one. It can be in-person courses. It can be from lots of different places. There's lots of free CPD online available. So just like we have to do IRMA, oral cancer, these types of CPD, then if you're a sedation trained practitioner or a sedation trained nurse, it's a good idea to get your 12 hours within the 5 years. So this one at the bottom, revalidation of trainer status. This is more for someone who is a accredited trainer who's training other people. So what that involves is a application form to the Royal Colleges, and you essentially have to give your logbook, you have to give what training you've had, and they will go through all that and they will make sure that you have enough training yourself in order to train other people. And once they give you the green light, you've got a validation for 3 years. So you don't have to revalidate yourself for 3 years. There's a small charge of like £100 or £150, and you get a certificate, but it's very difficult to actually get a response from the Royal Colleges. So when I was off on maternity leave, that's when I actually did my revalidation. So I was off for 12 months. It took them 9 months to get back to me and tell me that I've been validated. So this isn't something that's going to happen overnight. So you do need to plan in advance if you feel like you're coming to the end of your validation process. And the last thing that the document outlines is that you need to have adequate medical emergency equipment. And we will move on to this in the next few slides, but this is just about having airway adjuncts available for the patient. I'm just going to take a quick sip of water before we move on. So this is a photograph of my sedation setup. So this is what I set up every time we have a sedation within my surgery. So you can see there's a tourniquet just at the top, the cannula at the bottom. So my cannula is a 22 gauge, which is probably a very average size cannula, not too big, not too small. And you can get the majority of patients cannulated with that size. If you feel like your patients have got really tiny, teeny veins, you can go to a smaller size, but that's a bigger number, so a 24 or a 26 gauge. But most people just use this blue one and it works quite well. So you can see 2 syringes filled with clear fluid there. So there's one with an orange sticker, and that's the midazolam within that syringe. So I know that that's being drawn up and that's midazolam. The one next to it is some saline, because we flush the cannula when it's first been put in, and we also flush after each dose of midazolam. Just to make sure that there's no mistakes and no mix-ups, when you are drawing up, it's a good idea to have no distractions. You're not drawing up whilst you're getting your gloves ready, or you're not drawing up whilst you're doing your blood pressure setup. It's a good idea to get everything else set up, and then the last thing you do is draw up your midazolam, because the last thing you want to do is get those two mixed up. You've got some cotton wool rolls there. That's just to have a pressure bandage once the cannula has been removed. Alcohol swabs just to make everything nice and clean. And then I just pop everything in a kidney dish. I put all my sharps in that kidney dish as well, just to make sure everything's out of the way, and then I can get rid of them in my own time. So something simple and straightforward like this. If you have an order, you can see quickly when something's missing. If you're a little bit haphazard, it's quite easy to miss something. And then you're in the middle of sedating someone and you've got no saline. So just making sure that you've got an order like this just makes it a lot easier and more effective. So we spoke a little bit about controlled drugs. So we're just going to speak a little bit more about this. So midazolam is a controlled drug. So how do you get hold of it? So you need to be registered with the Department of Health as a controlled drug provider. So if you are a practice that has never done sedation before and you want to have your own midazolam, as in your sedationist will not bring the midazolam with them, you will need to register one of your dentists with the Department of Health. It's quite straightforward, but it does take a little bit of time. So again, if you don't want to delay your patients, have a chat with your sedationist and see if they have the drugs with them. So, for example, I take all my drugs with me, so you know the practice doesn't have to worry about ordering them or storing them. And you need to fill out a separate form, a Schedule 2 and 3 controlled drug requisition form, which can be found online. It requires information such as your NHS contract number or your CQC registration number if you don't have an NHS contract. And it just basically takes the information of your registered healthcare professional. It asks what you want. So you have to obviously put your midazolam down, how much you require and what you need it for. And then you'd send that form along with your order. If you're doing it online, so to Dental Directory, essentially, you'd scan it and then you'd also send the actual paper. If you're going through a pharmacy, a local pharmacy, then you just give that form in and then they'll take that off you and then obviously order the drugs for you. Because it is a controlled drug, it's controlled from the minute you get it to the minute you've finished. So the minute you get that box, you have to control that drug. So it needs to be stored in a compartment that's locked, so like a safe or a locked drawer, and that's where it needs to stay. It's not like local anesthetic that's just in the drawer. You can open it up and get it. You know, it's not like that. It needs to have something special. So for me, in one of the practices I work at, it's stored in the safe. And then disposal of midazolam too. So, for example, if you've got some midazolam left in your syringe, you've not needed it, the patient didn't need the full 5 milligrams, so you need to then dispose of that adequately. You can get little jars from like you know, the waste disposal companies. They can give you like a little jar and it's got like jelly inside, and then you can squirt the excess midazolam into this jelly and it just denatures it. But what a lot of people do is just spend it into a cotton wool roll or into a gauze, and then they can throw that away. It's a good idea also to be witnessed when you're doing that. So when I do it, I always ask the dentist that I'm working with, I'm like, can you just watch me whilst I spend this midazolam, just for you to have peace of mind that it's been disposed of properly. Just like I spoke to you about before, there needs to be a record of the use. So things like the patient initials, patient date of birth, how much you used, when did you use it, what date, and what did you do with the excess? Obviously, you got rid of it. As a practice, you might want to inform your indemnity and your insurance if you're going to control that drug, if you're going to store it, just because it might just have another clause in your insurance policy. Or if, like myself, I had to speak to my indemnity and tell them that I would be carrying midazolam with me, just so that I'm covered for that. Okay, we're nearly at the end, so don't worry, we're getting there. So this is what midazolam looks like when you order it. So it's in a box, 10 vials come in one box. So I just wanted to put this slide up so you can see the cost of the midazolam. So this is 5 milligrams in 5 millilitres, which is what a lot of dentists use, and it's only £10.91. Well, it's probably gone up to about £12 now. The next drug I'm going to talk about is called flumazenil. This is actually the reversal drug, and this is also available from like Dental Directory or Rights or from the pharmacy. And this is the reversal, and just look at the difference in the price. So it's a lot more expensive, and to be honest with you, we don't really use flumazenil that much. And we'll talk about that in the next slide. So like I said, it's called flumazenil or annexate. It's usually 0.5 milligrams in 5 millilitres. So it's got a lower concentration than midazolam has. And it's a single dose. So if you need to reverse that patient, you give the whole thing in one go. You don't titrate it like you do with midazolam. If you do that, it can be quite a sudden reversal for the patients. They might feel quite shocked and quite dazed. So do warn them. Be like, I'm going to reverse you now. It's literally like that. So they do find that quite shocking sometimes. You need to log when it's been used, similar to midazolam. The storage is the same, so it's probably a good idea to just keep them together, although unhelpfully the boxes do look very similar, so just be careful you're not drawing up the wrong drug. And there is a little bit of a question about should we just routinely reverse patients. It's probably not best practice, just because you need to be controlling your titration better. If you find that you're routinely reversing your patients, it's probably because you're not sedating them adequately and giving them enough time to recover. So airway adjuncts, this is just some examples of some airway adjuncts that you can have in surgery. First one's eye gels. So they come in different sizes. Usually the green one is what most practices have. So if you're thinking of introducing sedation to your practice, it might be a good idea just to have a little look in your emergency drugs trolley just to make sure that you do have eye gels. If you don't, or if you feel like you're not going to invest in them, then just speak to your sedationist and make sure they've got their own. To be honest, I think everyone needs to have eye gels, but it's just in case. The middle ones are Goodell Airways. Again, they're color-coded, just like the eye gels, but they're harder, and they go in upside down and they flick round. And then these are nasal, like airways. These are nasal airways. So these are only really going to be used if the patient has become unconscious, because essentially they become oversedated, and you want to protect their airway until help arrives, if you need to ring an ambulance or they come back round when you've reversed them. So just some other considerations. Discuss who is providing what when it comes to the travelling sedationist. So like I said, is the sedationist bringing the midazolam? Are you, as the practice, going to have the midazolam, and who's responsible for that storage? It might be a good idea to draw up just a little contract between you and your travelling sedationist, just to make sure everything's really clear, especially if you have sister practices or on other sites, so that everyone knows what's expected of the sedationist and what's expected of the dentists. It's important to know where the emergency drugs are and the oxygen. You need to have them in the same room or just next door, just something really close, because it's when patients desaturate, they can desaturate quite quickly, and we do need that oxygen on hand. Having nasal cannulas as well is something that some practices might not have, so speak to your sedationist, they might have some with them. Also, just make sure you're sedating patients in a downstairs surgery if you do have surgeries that split over 2 floors. Safeguarding, when a patient is sedated, no other staff member should really be entering that surgery. So we need to make sure that the staff in the beginning that the patient can see when they're not sedated is the staff throughout and the staff at the end. That's really important. Consider where the patient's going to recover. So do you have a separate recovery, or will they recover in the chair? If they recover in the chair, you're going to need more clinical time. So just make sure you consider that. Again, like I said about virtual pre-assessments. And once you've done all your sedation, everything's great, you've logged everything, the patient's left, you do need that to be scanned onto the patient's notes, because that's the only evidence you actually have that correct sedation protocol was followed. So please make sure that's scanned onto the patient's notes before you leave as the sedationist. And any payment or any future appointments need to be made before that patient is sedated. You might think that's quite straightforward and quite like common sense, but you'll be surprised about how many dentists actually don't take payment, or they need another appointment but it's not being made, and then that patient can't do that for 24 hours. So if you just got payment beforehand, it just makes everything a bit smoother. Okay, so that's the end of the presentation. I've just got my QR code if you guys want to follow me on Instagram. So we have quite a lot of posts about sedation and oral surgery in general, like hints, tips, anything that you guys need. And if you have any queries, there's my contact details, but you can always go through the female dentist and just contact them. So I'm just going to stop sharing my screen, and then we're going to go to the questions. So just do that now. I'll just check the Q&A now. Oh, Zoom won't let me. Okay, there we go. So just put your questions up on the Q&A if you've got any questions. If patients ask for sedation, shall we always listen to what they want? I think if they have a valid point, like the reason they want to be sedated is quite valid, then we should be able to offer them that treatment. It's a bit like if a patient needs a filling, but they're adamant that they want it to be a composite filling. If that's clinically justified, then I don't see why you wouldn't do that. So it's the same with sedation. I think you just need to take it case by case. And if you're not sure, you can always just speak to your sedationist or speak to someone who has a little bit more experience and just see what they say. But I would say that most patients can be sedated in primary care. So it is something that you can offer to quite a lot of patients. What medical emergencies have you had during your time as a sedationist? Luckily, I haven't had major medical emergencies, but I have had a patient who was actually vomiting whilst they were sedated. And in that case, it was really important to reverse them because I was afraid that their airway was going to be compromised. So I had to reverse that patient, obviously make sure that they were okay. And that's also a reason why we ask patients to be starved 2 hours before their appointment. So we don't want anything to eat or drink 2 hours before their sedation appointment because it can make them feel a little bit sicky. And this patient really felt it. And luckily, that's all I've had. I've not had anything too major. What is the most common side effect after sedation? Side effect as in a bad side effect. To be honest with you, we don't have a lot of negative side effects when it comes to sedation. It is very, very safe and it works out of the system within 24 hours. So if the patients listen to all of their advice, they should be absolutely fine. It's when patients don't listen to you. I think that's the hardest thing. So I have had a patient admit that they were being sedated. This wasn't one of my cases. I just want to put that out there. They were being sedated and they went straight to the pub after being sedated. And he was like, I had one drink and I really, really felt it. And I just looked at his face and I was like, yeah, because that's why we tell you no alcohol for 24 hours. Like we said, it enhances the effects of alcohol. So it actually can make the patients quite unsafe. So that's probably, that's one that I've had. Is there a maximum dose of midazolam you consider when you're in primary care? I've never really had to do more than 10 milligrams, but it also depends on your patient and those patient factors that we spoke about. So if you have a patient that takes midazolam, diazepam regularly, you might feel that you do have to give them a little bit more. It's all in a case-by-case analysis. But myself, I sedate them very lightly. I don't usually go over 3 or 4 milligrams. I do find that's adequate for most adults to be comfortably sedated in order for the operator to do what they need to do. Hi, Shafia, when would you consider reversal? So this one's, hi, Shafia, when would you consider reversal? If the SATs or heart rates are dropping a lot, would you provide it? Yeah, so essentially, if you feel like you can't pull that patient back, usually it's because they've been over-sedated. So if you feel like the patient has been over-sedated, that's when you're probably most likely to reverse them. If their saturation is going very, very low, you would give supplemental oxygen. But if that's not pulling their saturation higher, then yeah, you would reverse because sedation depresses the respiratory system and it depresses the cardiovascular system too. So if the patient is unable to be adequately saturated throughout, then I would consider reversal. What is your average fee guide on top of the procedure, for example, for an extraction under sedation when advising patients of that option? So this just kind of depends on where you are and who your sedationist is and how long your treatment's going to be. So it varies very much where you are in the country and also who you have. So I can only really talk about myself. So I charge about $350 for the sedation. And usually what practices do is they'll add a little bit extra, so they might charge $400. So the practice is making a little bit. And then when it comes to extractions, it just depends on what the extraction's like. If it's a simple extraction, surgical extraction, or impacted wisdom tooth. So just something to discuss. But to be honest with you, I've found that some sedationists charge a little bit less, and I've found some sedationists charge considerably more. So I'm kind of in the middle. But again, it just depends on your area and what's normal for your area. After how long you can discharge a patient after sedation? So the rule says an hour after the last increment. So if you've given an increment at, let's say, we're on 1959 now, you shouldn't really be discharging that patient until 2059. However, you have to take it from the patient and see how they are. If you can see that they can respond to you without a significant delay, they can walk independently, they can ask questions, they can understand what's happening to them, and you're happy to discharge them because you feel like they're just going to go home and relax, then you can take that decision and say, okay, that's fine. I can discharge you now. But if you want what the guidelines is, it's an hour after your last increment. How do you consent the patient? How do you describe the feeling of sedation and the risks? Oh, that's a good question, actually. So what I say is you will feel sleepy, but you will not be asleep. I also say that the treatment can feel quite distant, and you may feel like you're in the dental chair, but the treatment is being done in the waiting room. So you need to understand that there's like this kind of distance, this disconnect between the patient and the treatment, and that's what sedation does. It just basically gives them that distance away from the treatment. You can also describe it as being you feeling like everything's dulled down. It's not as sharp and it's not as in as much high definition as it is when they're awake. So that's what I say. Risks of sedation. To be honest with you, there's not lots and lots of risks because you can just reverse that patient. So losing consciousness is the biggest risk, desaturation, but you can deal with that. So it's more risks of the procedure. So if I'm doing extractions, I'll obviously consent for the risks of the procedure. If I'm doing something like, I don't know, composites, it might be sensitive afterwards. You might have some gum pain, occlusal pain. So just consenting them for the actual treatment. But when it comes to sedation, it's just making sure that they understand what they're having done and why they're having it done, and they've got an escort ready and they can afford to go home, because the last thing you want to do is have to cancel that patient because they didn't understand their pre-op instructions. When is the patient allowed to eat or drink afterwards? So they can pretty much eat and drink straight away afterwards, but most patients won't want to. They'll feel very sleepy and they'll probably just want to go home and go to sleep. But that obviously is procedure specific. We probably advise the patient to wait for the numbness to wear off before having something to eat or drink, which we would do usually. Can dental nurses doing the training and administer the sedation? Okay, so dental nurses, if they are sedation trained, they can help you. They can help monitor the patient. They can actually even help with the pre-assessments, and they can recover that patient. However, it's only a dentist or someone on the register for the Department of Health that can actually administer the drug. Nurses can also actually get some further training to do cannulation, but the actual pushing the midazolam through the cannula, that's only really by the dentist. As a traveling sedationist, do you also bring a sedation trained nurse? So like I explained, if the practice needs a sedation trained nurse because they're going to use me as the sedation operator, then yeah, I have had a discussion with someone I know who's a sedation trained nurse if they could come with me. And if this is something that the practice would like to implement, then that's just something you need to speak to the sedationist about. But most of the time, like I said, I'm usually just doing the sedation, so I wouldn't need an extra nurse. Like I said, the dentist and the nurse are fine to just be there. Okay, I think that's all the questions. If there's anyone else, any more questions, this is your last chance. Okay, that brings this webinar to the end. I really appreciate you taking the time out to listen to me today. It's my first webinar, and I really appreciate all the support from everyone that's took the time to speak and put on the questions. And hopefully we'll see you soon in another female dentist event or in another webinar. So thank you very much and have a great evening. Take care, bye.